signing out one patient where he started to say something like that this patient is no longer responding to my. Okay, there you go. Thank you. I was getting sent out this patient, and the physician sending out to me said she's refusing care, she's demanding opiates, she's an injection drug abuser, she's difficult, and she's going to die. So think about that. Amongst the 12 other or so patients I'm receiving, this is the beginning of the sign out, and picture how you feel hearing this. The next morning, I've got the team. We start rounds. We go to her room. We walk in this unlit room. She was a 30-year-old woman, active heroin user, who had recently diagnosed aggressive T-cell acute lymphoblastic leukemia. And when I looked at her, at least one thing I heard seemed true. It really looked like she was going to die. Her eyes were sunken. She had temporal wasting. She was looking down at the floor. And she then looks up and says, I'm really frustrated. She was upset about the care she was receiving. She felt that nobody cared about her, nobody trusted her, and she was overwhelmed with her condition. And she said, I'm leaving today. 10 minutes into my rotation, we're at quite a crossroads. We could have gone and grabbed the paperwork and had her sign out AMA and walk down that hallway to what seemed like certain death. Certainly had a lot of other people we could take care of that day. We've done things like that before. But let us back up for a minute. I want to talk about trust and how often do we think about the concept of trust in healthcare and what that means and how do we target it. And I know some of you may already be like, oh boy, we're in for really squishy grand rounds. I want to reassure you, as I just mentioned, I am a practicing physician. I go to Morning Report frequently, actually, because I love working through complicated cases with my colleagues and with the trainees. As a resident, I really focused my energy on learning the right medicines to prescribe, the right test to order, because that makes a good physician, right? But I've come to realize that knowing the right medicines to prescribe and the right test to order, that just makes you a competent physician. And competency is the floor, not the ceiling we should be striving for. It does not make you great. In order to be great, I think you need to know more than what is the right antibiotic, but rather how do I get my patient to take that medicine? And so much of that hinges on trust, whether they trust you and what you are saying. And while there's no set definition for trust, the generally agreed upon conception is that it is the willingness to be vulnerable under conditions of risk and uncertainty. That is what we do every day. We've got patients who are incredibly vulnerable under incredible risk and uncertainty, and yet we're asking them to be even more vulnerable, to put their trust in what it is that we're doing. It is really the key thing, I think, to whether patients seek care, continue to seek care, adhere to treatment. And in fact, there's a lot of evidence around this. When people have studied trust, they found that acceptance of, okay, I'll stay over here. Acceptance of antiretroviral therapy among people with HIV hinged largely on whether they trusted their physician. Those who trusted their physician more were more likely to take antiretroviral therapy. This is also true about immunosuppressive therapy among people with lupus. This is also true when they studied it in diabetes and hypertension and cancer. Patients are more likely to adhere to treatment recommendations if they have a sense of trust. Problem is, while trust is the house that our entire foundation is built upon, it's cracking. It's pretty clear that over the last number of years, particularly spurred on by COVID and everything that occurred during that, trust, particularly in institutions, has been declining. Essentially across the board, people do not trust institutions. And they specifically don't trust the medical system. So in a lot of ways, we have just been caught up in this kind of global phenomenon of mistrust and distrust. But since we're going to talk about trust, I also want to be really clear. I think when people talk about mistrust and distrust, we really run the risk of making it their problem. They don't trust us, as if it's their fault, their shortcoming, when truly trust is based on trustworthiness. The question is the medical establishment worthy of people's trust? It's our responsibility if people trust us, not theirs. It's not their fault. And I think that there are a number of things when people are getting bills in the mail that are asking them to choose between their life and their life savings, when they're hearing things like that a lot of the care we provide is unnecessary, didn't make them healthier. It makes sense that people are starting to lose trust. But there are things we can do about it, all right? I feel everybody getting bummed out. We're gonna turn this around. One of my colleagues, Daniel Wilson, the ABI Foundation, wrote about what are the ways that health systems can enhance trustworthiness. And I think this is important because it's a nice framework as we think about what we can do as individuals working within these systems. The other thing that's tricky, by the way, is I'll point out trust generally is based on a relationship, communication, a track record. And traditionally, that happened between a patient and an individual physician. And increasingly, that's no longer the case. A patient doesn't get their care necessarily from Dr. Smith, they get their care from USC Keck. That's okay. I mean, it's not like that's just the way it is, but it's harder to build trust when the front door is USC instead of a face and a name and someone I know and I can talk to. So what can the systems do? Well, they can show that they're competent. They can show that they care about me, that they communicate in ways that humanize me, and that they make me feel safe and comfortable. So 4 C's, pretty straightforward. Competence, caring, communication, comfort. I promised some alt rock. We're gonna sprinkle some alt rock through this. So as I thought about how do we build trust within these systems, and as we're going to talk about how do we sort of use our wiggle room within these systems to rehumanize ourselves and our patients, I started thinking about the music that I love. And I was a 90s kid. I grew up in the 90s. I grew up on Pearl Jam and Nirvana and Rage Against the Machine. And the thing that I think really defined a lot of these bands is that they distrusted institutions, but they didn't disengage from them. So I'm not here to say, this is all broken. We should stand outside and throw bricks at the medical establishment. We actually need to engage. We need to call out what the systems are actually supposed to stand for. That's our job. Our job is to do that. And so I thought a lot about this because hospitalists were built essentially to be good system citizens. You've ever heard that phrase before. But the idea was we're working within the hospital. We know how to make the hospital better. And what does being a good citizen mean? Well, we know it means being engaged with your community. It means trying to make things better around you, improve. And so it's important that our role within the hospital system is that we're engaged, that we're trying to make things better around us, that we're serving the system and the group. And yet, how do we serve as good system citizens and also appropriately rage against the machine for our patients when the system is harming them? The system is doing wrong by them. So I believe strongly in us being good system citizens. But like I said, I grew up with these punk rock ethos. Actually, Friday night, I met up with my old high school friends. I've done this a long time. Last Friday, me and my old high school friends, we went to Novo, it's called. If you guys have ever been there in the LA Live. And we saw Face to Face and Unwritten Law. Bands who I hadn't seen in 30 years, which made me feel both young and old at the same exact time. I was with my high school friends, and like looking at them, I felt like I was 18, and then I also was like, oh God, we are not 18. Face to Face, Unwritten Law, like how do we rage against the machine? when I was 16, actually, I had midnight blue dyed hair for a while. And the thing about midnight blue dyed hair was it looked pretty respectable and dark, just in the classroom or wherever I was. But out in the sun, it kind of shined bright blue. And that was the type of subversiveness that a straight A student gonna go to med school, but wanting to go to Warped Tour and listen to Rancid with his friends on the weekends could strike. So that's what we're looking for, is like that little bit of midnight blue hair that we can find in ourselves within this system. I am a systems guy though. I want to say, like, I was a associate chair for quality and safety in Austin, assistant dean for healthcare value. Like, I was the quality and safety guy. Like, I believe in the power of systems and creating force functions and safety. So we need to figure out how to balance those two things together. I don't know if this reference hits you all, but Nirvana, when they went on the cover of Rolling Stone magazine, Kurt Cobain wore a t-shirt that says corporate magazines still suck. That's the midnight blue hair thing. That's the, I don't trust institutions, but I'm not disengaging from them. I'm going to be a part of this, and I'm going to say this is what you should stand for. These are the bands you should be listening to. These are the ideals we should be pointing out. All right, I know a bunch of you may be on Teams, but for those in the room, I want you to just take a second and turn to your neighbor and just talk about what was the music of your youth. It doesn't have to be quote cool, I don't care. But just think back to when you were in high school. What's your favorite like band, singer, musician? Share that with your neighbor.
Britney Spears. As you know, not as much as yeah. Then it's looking right. You know, I recently played 3 day for my raise shop.
Like it was a couple, like the sister of my classmate. Yeah, it's really just Green Day like
Everyone share. What do we got?
so
What was your favorite?
Green Day, Weezer.
Yeah, right on. I'm gonna tell you my Weezer story. Cool. What do we got over here?
Madonna, Michael Jackson.
Yeah, cool, very cool.
We're pretty on the nose. Ours is Pearl Jam, Nirvana, Offspring, Green Day.
Yeah.
In there.
Yeah, right. Yeah, exactly. That's how they came out. This is the only icebreaker I like, by the way, is when I rotate on service and I meet the team. The only question, I ask them like, where did you grow up? What do you want to do when you're done with training? And who was your favorite band or singer in high school? And I like it because it actually, like, you learn a lot. And so you're like, oh yeah, he's the emo kid. I didn't end up paying, or like, I didn't realize. And actually what it does a lot of times, these interns who've been working together for a long time and thought they knew each other so well, are suddenly like, what? Like, you loved Taylor Swift too? Okay. You guys know who that is? So that's Don Berwick. Don Berwick is a pediatric intensivist by training, I believe, but that's not what he's known for. He's known for starting the Institute for Healthcare Improvement. So the IHI, he started. He then, at some point, he was the administrator for CMS under Obama. So he ran the Centers for Medicaid Services under Obama. And then he actually ran for the governor of Massachusetts. Okay. Do you think that, Don Berwick is the man? Like, this was like, he was the administrator for CMS. He like wanted to be the governor of Massachusetts, ran IHI. But he wrote this article about breaking the rules for better care, about how sometimes it's actually important to break the rules to get back to our primary principle of our responsibility to our patients. And he gave some examples. One of the examples was from a family member talking about how a nurse broke visitation rules so that the mom and baby could be together, and that breaking those rules made all the difference. And when I read Breaking the Rules for Better Care, I'm like, Don Berwick is kind of punk rock. He just kind of brings it. The IHI formalized this. They had a Breaking the Rules for Better Care initiative where they pulled together health systems and health system leaders. And essentially they asked the health systems to have campaigns within their system, asking the people who worked on the front lines, if you could break or change one rule to take better care of patients, what would it be and why? And they collected those answers. And when they did, they kind of created a taxonomy, which they said, look, there's some rules that should be broken because they need clarity. They're like myths or things that you're like, is this even a real rule? Why does this exist? This, I don't know if it's like this at PEC, but at the VA, all the rules are myths. But they're told as like very straightforward. The nurse says, oh no, on 3 East, you can't take blood sugars out. You're like, where is that written down? But it's like, no, that's the rule. They must go upstairs. I'm like, what? And so there's rules that need clarity. There's rules that need redesign. So rules that we all know like may have made sense at some point and now just like make absolutely no sense. The purpose or the point of the rule underneath it might make sense, but the way it's being administered makes absolutely no sense. And then there's rules that need advocacy, ones that like, we can't change the 3 midnight rule, but like these are things that we should all advocate together for to change. Okay. But we're talking about these like big, how do we advocate within systems? How do we try to change bigger rules or do things, which I think is our responsibility as good system citizens to stand up and say, hey, wait a second, this rule is not serving our patients. Like someone needs to do something about this. But there's something that I think we can really do within our everyday lives. I learned about this concept of, it's pretty simple, but it's just wiggle room. That actually when you work, even within the confines of an institution and rules and all the things that I work in every day within a VA, I actually have like, just as an individual person within the system, wiggle room to do things on my own. And taking the initiative to do that. My friends and I in our division started calling this our punk rock moments. So I had a patient, he had a septic elbow, he had HIV, he had a septic elbow, he needed to get it washed out. We go to see him on rounds. He's super upset because he's on PO. The orthopedic surgeons won't tell him what time the washout's going to happen. I don't know what times the washout's going to happen. He's very mad about it. He wants to smoke a cigarette to calm down. And he says, you know, you guys are not letting me smoke cigarettes. You're not letting me eat. Like, this is insane. I'm leaving. Actually, he didn't say I'm leaving. I'm sorry. He said, I'm walking outside to have a cigarette and I'll be back. And the nurse said, absolutely, that's against the rules. You cannot leave. And so I'm sitting there and we're at like a standstill. And eventually I realized like, man, because I'm talking like, you need this thing washed out. Like this, you know, you need this. Then you can do what you want, honestly. I hope you stay with us because you need more treatment, but like, at least get that done. And I said, hey, come on, he's not a fall risk. He's fine. Like otherwise he's gonna just leave and not get his procedure. You guys are gonna burn this whole thing for him. And the nurse was like, absolutely not. And then I had this moment where I said, wait a second. I've worked so hard to be the attending physician. I'm even the division chief now. And I was like, if I don't use that power, who's gonna use that power? And I said, actually, I'm gonna walk him downstairs. And of course the nurse said, what's your name, doctor? And I was like, MD aware. Put it in the chart. Come on. And me and this guy walked downstairs and we got about 10 feet. I'm going, oh God, I'm making a big mistake. This guy's gonna fall. Like, this is gonna be a big problem. But as I was going outside, it was incredible because I saw my patient a different way. This guy apparently was like a legend around the VA. I did not know that. I just knew him from his room. As we're walking downstairs, literally people are like saying hi to him. And he like walks by some dude and he's like, hey, you got a cigarette? And the guy like grabbed a cigarette for him. I'm like, what? Like and he goes outside and we sit down for a smoking break. I was not smoking. And I don't condone him smoking, just to be clear. But it was some harm reduction. And he starts just telling me about his life and about his dad in the Hells Angels and like all this stuff. And it was just incredible. And I just sat and listened, which was a nice 10-minute break for me from the craziness of the hospital. And he calmed down, right? And he said, okay, what do you want me to do? And I said, I want you to go back to your room and we're going to do this procedure. And he did, and he got his elbow washed out. He left AMA the next day, but he got his elbow washed out. And I was like telling my friend about this story. And he's like, Chris, I did pretty much the same exact thing 2 weeks ago with somebody else. Like they were going to leave, I walked them out. And so we're like, yeah, those are our punk rock moments where we're like using the wiggle room, our power within the system to do something. So I want you to turn to your friend again. Oh, sorry, I'm going to quote myself first. We alone can bring the ideals from our classroom, such as autonomy, shared decision-making into our clinical settings. Systems cannot care. They are systems. We care. We can provide care. Systems can do a lot of things, and they protect, but they cannot care. So if we want to care, that's on us. All right. You might have a punk rock moment. It can be very small. It could be like, oh gosh, one time I went and got a cupcake for my diabetic patient because it was his birthday. I stuck him a cupcake, or I don't know what it is. It could be anything. It could be I lied about having a pickup from the post-op colonoscopy. And I waved at a car that wasn't my daughter, and I left. That was a great story. You should share that one again. All right, share your punk rock moment if you have one. All right, with each other. Go for it.
Mine be the one that was trying to like kids.
No, I didn't. Yeah.
Yeah, like some people out, like they couldn't.
Yeah.
There's like nothing. It wasn't like this. It was in that. It was that day. What they do? Yeah. And they don't. Scientists have this video. But I start getting some good arguments. I felt like that was easy.
Sometimes it's also that's it's there.
Exactly. Oh, right.
You want to? That was risky. It was wild. It was just.
I was like, not good. It's been cool.
All right, we can stop. Keep talking about it when you leave. Hopefully anybody on Teams is thinking about moments they've had, reflecting on it, sharing. But now I want to put some guardrails around this, okay? Because you're going to go back later today and you're going to be like, Dr. Moriates told me to break all the rules. And I'm going to say, first of all, Dr. Berwick told you to do that. Berwick from JAMA said break the rules for better care. But no, it's important that we think about these. It's like our times to do it, but let's put some sort of guardrails that I made up around punk rock moments. So one is, obviously the principle needs to be it serves the overall goal of patient well-being, safety, and autonomy. It's not about breaking rules to break rules. It's about doing it in a way that serves patient well-being, safety, and autonomy. If following the rule would result in imminent or significant harm to the patient, then you probably shouldn't follow the rule. I would argue, although this might be stretching it slightly far, but that's in a way the principle I was working out, where I was like, kicking this guy out of the hospital because he's about to go have a cigarette is actually going to cause imminent harm because he's not going to get this procedure. And I think that's silly. You got to respect the patient preferences and values. You need to ensure that it adheres to ethical principles of doing good, avoiding harm, providing patient autonomy and justice, and that you feel you have a moral obligation to act in a way that benefits the patient. But in addition, I think it needs to be calculated risk based on your judgment and expertise, which also means that there's gradations here. What I was able to flex my power as the new division chief is probably different or should be different than what I could have done as a first month attending or a resident or an intern or a medical student. I believe that all those people should have some wiggle room and should figure out ways to like work within the system, maybe sometimes break some small rules to take care of patients better, but it needs to be within their level of expertise to make that judgment, to say that this is safe, this is appropriate, this is good for my patient overall. And essentially, it shouldn't break a law or a regulation. I'm talking about breaking like hospital rules, not breaking laws necessarily. And you should be ready to transparently report the action. So that's the big thing. Is like, I was totally prepared that when that nurse wrote that down, even if something like bad happened, even if the patient fell or something, I was absolutely ready to explain exactly why I did that. Or I was happy to write in the note, patient was threatening to leave in order to get his procedure. We walked outside. So you need to be able to, if you feel, hey, I would happily explain what I'm doing. I feel like there's this justification to what I'm doing, and it gets back to the principle of taking the best care of my patient, then I think it's the right thing to do. Okay. So back to my patient, 30-year-old woman, active heroin user, T-cell ALL, says she's leaving. I'm like, you shouldn't do that. We're also like, hey, notice you're on oxygen. You've got this big malignant pleural effusion. It's fluid. It's trying to drown you from the inside out. How about we try to make you feel better at least? And if you want to leave after that, I'm not a jailer, but let's at least see. And so we talked to her about draining the fluid, and reluctantly she agreed. And again, could have sent her down to IR. How would I do now? Because I haven't done a thora now in a couple of years. At the time, we said, no, we're going to do this at the bedside. Dr. Baig, my resident, and I are going to come back after rounds. We came in with the ultrasound and with our kit. And we set up, and everybody was nervous in the room. But as we started to do the procedure and as the fluid started to drain out, you could feel everybody breathing easier. And it gave us this opportunity to just start talking, speaking with her. Because we're all there, captive audience. And as we were doing the procedure, Dr. Bing noticed she had all these tattoos all over her body. And one of the tattoos was AFI, this old punk emo band. And I was music editor at the Daily Bruin at UCLA when I was an undergrad. And so I used to go to all these concerts. I had interviewed AFI at a concert at the Palace. And so Mirage, my resident, says something like, oh, you like AFI? And then she's like, oh yeah, blah, blah, blah. And then I was like, oh, The Art of Drowning is a great album, right? And she's like, who is this? Like, did not guess that. And we started talking about it. And then I find out, which I didn't know, my resident was like into weird Norwegian like death metal. And like her and him just start going back and forth on these like crazy like Norwegian death metal bands. And they just start connecting, and suddenly things were changing. We were building trust through the shared interest of punk rock. Now, you don't have to be a music person. That's not the point of this story. You would have found something to connect with her about. You just had to look. We found AFI and Norwegian death metal. But if you talk to her, I think you'd find something. We had that moment. We talked to her about it. And we started building trust. She decided to stay. And when you tell the story this way, I feel like it's, you know, it feels like there was a light switch that we suddenly switched on and suddenly everything was great. Like, clearly that's not how it was. I think it's much more like a candle that sort of started to flicker. And at times we would come in the morning and she'd be all frustrated again and mad and be like, I thought we had the thing. The candle's going out. But over the course of a week taking care of her, that bond, that trust started to grow actually between us. We were seeing each other. And in fact, towards the end of, I don't know if it was a week or a week and a half, and it was on for 2 weeks, I know she said, my birthday is this coming weekend. and I've got a friend who's gonna come over from London, and I think it might be my last birthday. And I thought she was right. And she said, I don't want to spend it here in the hospital. And we talked to HEMOC and they're like, it's impossible because she needs to get intrathecal chemotherapy next week. We're like, but you're not gonna do it this weekend, right? They're like, no. And I said, but they're like, but we can't, arrange whatever. And so they said, the only way is if she leaves AMA. If she leaves AMA, they might not agree to continue to give her intrathecal chemotherapy, which I was like, oh my God, guys, what are we even doing? But my team, Mirage mostly, went and started talking to the case managers. I went and spoke to the CMO, and we were able to do something that I don't do for patients, but we were able to make an exception. We got the CMO to say, yeah, okay, she can go and she can get this, we'll ensure that she can come in and get this intrathecal chemotherapy on Monday. Like, we'll put it all in the chart, we'll do it, we'll organize, we did it. And then we were able to sit down with her and say, look at all we did for you. If you use heroin, you're gone. Like, that could be it. And she told us she wasn't going to, and we trusted each other. And the amazing thing is, what I saw in this case, it's easy to draw in this case from the many, many, many cases that didn't go this way. From this case was there was this halo effect that then extended. When we met this woman, like merely a week before, she had zero trust in the healthcare system. Nobody cared about her. Nobody was going to do right by her. She was just going to die. And suddenly, because my resident cared, because he connected with her, because he went the extra mile to set up this and let her go for the weekend for her birthday, we saw that she then had so much more trust in kind of the overall system. And we followed up with her. She started having a notebook where she was keeping track of all her appointments and all of her, procedures and things happening. And months later, I think it might have been about a year after she was discharged, Mirage and her ran into each other. And the amazing thing is, I cannot explain to you how different these two people looked than the day they met in that hospital room.
Yeah.
She's put on a lot of healthy weight. Like Mirage had to tell me that was her, because I'm like, what? But she had gone through an entire cycle of chemotherapy. She was doing well. Put on weight. She even told him that she had met somebody in the waiting room at the infusion center, and they started dating. And Raj is like, if that's not wrong, he's like, that's just like Garden State or something. Amazing. That's pretty amazing. And I think this really all came about because we found that opportunity to work within the system, but create the exceptions to show that we care. I want to provide some evidence about other little things that we can do, because that also feels perhaps overwhelming. And we can't make exceptions with our CMO for every patient. We can't even spend the 30 minutes to do the thoracentesis for every patient. Like I live in your real world, I do. I know it's easier when I'm sitting up here, but I live in your real world. But there are little things that we can do that actually have profound difference. And one that I've really come to recognize is around words. We thought about how we felt when we heard this. Having never met her. I don't know about you, but I'm like, ugh. Another defiant patient. I've got a lot of things to do today. It's actually some of my words. These are Dr. Epstein from an article he wrote in 2013 that I've essentially been carrying around in my virtual pocket for the last 13 years now. Dr. Epstein wrote this paper, Not Just Words, and I was a first year, I guess, attending, and it really hit me. And like I said, I actually have now, for the last 13 years, almost always taught this on day one when I'm with my team. So guys, there's a lot of language that is entrenched in healthcare, and it's not your fault. But I want us to try when we're together to use other words. So I say, especially with the VA again, patient refused. On that first day, it probably came up 10 times. Like, when I rotate on Saturday, but you'll be like 10 times. So I try to not make them feel bad. I'm like, look, it's not your fault. It's what we use. But refused makes me feel like I'm fighting with them. It creates this antagonism. And God forbid, the day that I'm hospitalized and you try to stick me at 4 in the morning with a needle to the arm, and I know that my blood count is fine the last 2 days, Dr. Moriates is going to refuse. And so we talk about what are better words you can use, because it's important to get across why you don't have labs that morning, or why they didn't get the cath. And so we think together and usually come up with the same list that Dr. Epstein did. We say, hey, patient declined, or patient preferred, or patient opted not to. Because I've seen, like you probably have, I've seen the patient who came in with an NSTEMI and cardiology said, oh, last time they refused cath. And you go talk to them and it's like, oh no, last time the doc said I didn't really need a cath. It was like it was a conversation and we were deciding and I decided not to do it. But if you think I need a cath now, let's do it. They're like, that's very different. But they stopped at the word patient refused cath. And so these words make a big difference. And I'm sure you guys are familiar, ASAM has a whole campaign around this, that a lot of the words that were used in that stem from the doc who's handing off this patient just creates this image. And as we'll talk about, it's not about being word police. I'm not interested in just saying like, oh, let's use nicer words. And I do think we go too far on this sometimes. I also make fun of sometimes some of the language that we end up trying to push in the, that I don't think actually helps anybody. But in these situations, I think they do. I was trying to figure out how to tie this back to our rock theme. But a lot of the early 20s rock was actually really attentive to language, that just making small shifts carry a lot of emotional weight. And that's what we're talking about. If you make small shifts, you can carry a lot of emotional weight. But like I said, it's not about just using better words. I'm going to show you there's a lot of evidence. This is evidence-based, that it changes how we feel. And then that changes what we actually do. And that changes what the patient outcomes are. Lots of studies on this. One was in emergency medicine physicians. They found that those who used the word sickler to talk about patients with sickle cell disease had more negative attitudes towards patients with sickle cell disease. But the important thing is that those negative attitudes were then associated with lower physician adherence to national guidelines for pain management. In other words, they said sickler, which made them think a certain way about that patient, which actually made them prescribe fewer pain meds against guidelines. They pointed this out on the Pit. Do you guys watch the Pit? They had this exact case, basically. Like, I think they draw from the literature. I mean, that was like, literally, they were making this. Sometimes I feel like the Pit makes these like crazy PSAs. I love it, but it's like, I feel like they turn to the camera and they're like, so, yeah. This podcast I listen to goes, living out with the Pit. So they make these liberal points. Okay. They also studied this in JGym, where here's what they did in this one. They created these vignettes that the students looked at. So we're all familiar with case vignettes. And it had 2 notes of a hypothetical 28-year-old man with sickle cell disease. Okay. So they're describing this hypothetical young man, sickle cell disease. You've never met the guy, he doesn't even exist. All you get is the vignette. And the vignette was presented in 1 of 2 ways. One used neutral language. This man has sickle cell disease and is having pain. And the other, describing the same patient, used stigmatizing language. Like drug abuser, or things that people were thinking. And they gave it to 413 physicians in training, so medical students and residents in internal medicine and emergency medicine at an urban academic medical center. All right, 54% of them actually did the vignettes. Okay, so they got these vignettes, they were randomized to which one they got, and then they answered questions. And if they saw the stigmatizing language in the note, they had strongly more negative attitudes towards this hypothetical patient before they've ever seen them. And when they were asked about what they would do to treat the patient, they consistently provided less aggressive management. So exactly what we said in that other real world study, they showed it in this study. And for anybody in medical education, which includes you all, here's the part that really scares me. The resident attitudes were more negative than those of medical students. regardless of harm, actually. So whether they got the neutral language or the stigmatizing language, they still were more negative and more cynical than the medical students. And in fact, there was an inverse correlation between years of training and their score on this. We are training them to be more biased. We are training them to be more cynical. We are training them to give worse care. The longer they're in the training environment, the more that this stigma spreads. And then another study, some of my colleagues looked at stigma in the medical chart and associated it to diagnostic errors. The stigmatizing language in patient documentation was associated with diagnostic error and multiple diagnostic process errors, which we also know. We take shortcuts. Biased language affects behaviors of future clinicians who read the notes. Much like the example I told you about the person who refused CAP, this is well known that stigmatized patients enter a reinforcing chain reaction where something is put in the chart that then influences the way I experience them, which influences how I treat them and document about them, which then continues. And in one paper I was reading about this, it said negatively characterizing patients can unfairly penalize them for a bad day. And that hit me. And the reason that hit me is because I immediately thought about being a resident at UCSF, being the admitting resident on call. The second-year resident, carrying the admission pager in the good old days when we did 30-hour calls. And I was feeling overwhelmed. And the emergency room attending called out a patient to me. And I was extremely rude. I was a second-year resident. She was a full attending. And I was very rude about it. Said a couple things. One of the things I said was like, I didn't think this patient needed to be admitted. And she said she needs to be admitted for an expedited workup. And I said, no, we shouldn't admit people for expedited workups. And she said, we do it all the time. And I said, no, you do it all the time. Yeah, E. And the next day, my associate program director pulled me aside. But the thing is this, I'm really embarrassed about that. In fact, usually I don't retell a story, but I feel like we're friends now. What if that was in my permanent record? What if every time I went down to admit a patient, they pulled up and it said, rude. Rude to the staff. And that colors every interaction I have because I had a bad day. I apologize, by the way. I tried to do my best. I worked with that emergency room attending for like 7 years after that, but anyhow, so that when I read this, I knew it was about patients, but it put me in that moment. I said, yeah, that's not fair. Okay. The other small things we can do, I realized that improving trust, it's hard. There are things we can do around our language, around our caring, the things that we show that we're competent, that we care, that we make you feel comfortable. Those are things we can do. But at the end of the day, it's actually easier to gift trust to someone else than to get it for yourself. And a simple way we can do that is with our handoffs. So when you rotate off, a lot of times we just like ghost the patient essentially. Right? They like don't realize, and suddenly a new doctor comes in the next morning, and that erodes trust. If you can, think about how far it goes to say, this is my last day. I've been here all week. I've been here for 2 weeks. Tomorrow, I have my colleague coming in. He's fantastic. Such a great doctor. You're very lucky. And I'm going to be signing out to him tonight to make sure he knows everything we've done this week. Something to that effect. Don't lie. But I assume you think most of your colleagues are fantastic. I heard about the SNFs program, right? And you guys said, and someone said like, oh yeah, when we walk in and they see that it's a USC doctor that's seeing me in the SNF, they light up. And I was like, yeah, that's exactly. Think about that. Hey, you're going, but you're going to see my colleague who's going to check on you there at the nursing facility. That actually changes the whole trajectory. And that patient, I think it aligns them and it gets them to start trusting. Okay, lastly, I realize we're running out of time here. I think the step beyond that, so these are all individual things that we can do in our everyday lives, right? Just to review, we can advocate for systems changes, we can learn about rules that make no sense, we can talk about why these rules need to change, we can find the wiggle room within our everyday lives to break the small little rules for our patients, to do things to recognize their humanity. We can use words that are person-centered, that actually help us feel better about our patients and then take better care of them. We can give trust to our colleagues, which builds trust within our system and our medical care. And then I think we can actually build teams that are focused on addressing trust as like an outcome within medical care. And so the B team, which we call this the buprenorphine team, was a team we started in Austin to treat opioid use disorder. So when my patient with the heroin use, we didn't treat, like even though we took care of all this stuff, we actually did not start on buprenorphine, I have to say. It was not in my toolbox then, but it is now. And this team was started as a multidisciplinary team with hospitalists. It was hospitalist-led, but there were residents, there were medical students, there was palliative care doctor, there's a psych doctor, there's a case manager, social workers, all these folks that created this interprofessional team. And one of the outcomes that we were interested in was not just treating opioid use disorder, but whether we were building trust. And if we think about that as like an outcome that we want to target and design for, I think that shifts what we do in our improvement work. So trust, I would argue, is a fundamental organizing principle in healthcare, but we often don't recognize it as such. And I'm going to leave you with a couple lessons I learned from Pearl Jam. One is, fight the system, but stay true to your mission. Because may or may not be aware, they fought Ticketmaster because they wanted to keep their tickets under $20 for their fans, which is laughable now. Last time I saw them, I think it cost me like $500. But at the moment, they were fighting the system, even though it actually didn't serve them to do so. And they've evolved over time, but they've stayed authentic to what they want to do. So they've evolved, they stayed authentic. They prioritize community. So the other thing is they stopped making like music videos and doing this stuff, but they really focused on their fans and their fan base. They have a fan club and they like created a lot of community amongst their fans. And they that helped build their credibility. They were always standing for something, like pro-choice was an early thing that Eddie Vedder was very open about. They were standing up for these causes that they cared about, but it never felt that it was opportunistic. It always felt genuinely aligned with what they were doing. And they realized that they figured out early that trust comes from consistency over time, not perfection. They've made plenty of missteps. They've done things wrong, but they were consistent with their community. And that has developed trust amongst those of us who still care. So I want you to think about, we won't turn to each other because it's against the hour. I apologize. I don't usually go up to the end here, but I want you to think about when you're leaving, one thing that you aim to do differently based on today. It can be small, it can be big. It could be, I'm going to not use the word sickler. I'm going to talk to my team about not using the word refuse and explain why. I'm going to share Epstein's article. I'm going to, whatever it might be, I don't know. But think about a lesson from today. Because I would say we have a crisis of eroded trust in healthcare. And there's a lot of reasons we're untrustworthy, but we can be noisier and we can do right by our patients. And there's simple things that we can do within our everyday lives. That's the end, although I was told I have to give you a mock question to make this count for your mock points. So here's our mock question. You guys can read it. Everybody want to shout out an answer so we all get credit?
C.
All right, C. As we talked about today, language shapes clinician attitudes, downstream behaviors. Everybody saw it, everybody heard it, everybody gets mock credit, I think. I want to thank you guys. This has truly been a really great experience for me to get to know your group more and to learn about what you're doing. I did make a playlist. If you want to listen to my Subverting Systems playlist, it's on Spotify. You can check it out there. But thank you very much. And I can hang for questions. I'm sorry I went right up to the end, but I'll hang. And yeah, thank you. Any questions, comments?
How often do you get called into the principal's office?
I mean, you know, it's funny. Not often, and that's actually the truth too, which is like, I don't know. I'm trying to think. It's not like I'm out there breaking rules. I like nobody. I don't know if my boss would think of me like that, but I definitely think that they realize I'm the person who, like, when we started the B team, we'll get the minimal permission that's required, and then we'll just do it. Because what I think is we spend so often trying to get like approval and let's get everybody on board and all the stakeholders and everything. And I was like, that's great. Let's just make it so that the principal says like, I won't get in your way. And then let's just try, like, treat that patient with bupe and let's see what happens. You know, because we're going to roll it out. So anyway, short answer, I know, but I think that's because it's just like, it's part of what we do. It's not like I'm not a rabble rouser really. Yeah.
That's exactly right. If you explain what you're doing to the right people,
yeah,
it's actually very rare you get pulled in the principal's office.
Yeah. 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 It's not about being a rabble rouser per se, but it's about, you know, reclaiming our power.
Misinformed.
Yeah.
Very opinionated about healthcare.
Yeah.
Oftentimes entitled in terms of trying to dictate care.
Yeah.
Like how would, just as an example of that situation, how would you approach that differently rather than like where you're starting from a very different point than your example?
I am not an expert in this space. There's increasing experts around what to do with mistrust and like distrust. So I don't want to like get in over my skis too much. You know, I'm talking about ways that we can like build trust, but how to deal with